Hey, RadPathers. This is Matt Hartman coming to you from Pittsburgh, PA. I am the RadPath editor for this channel. And special treat today, we'll be talking about uterine pathology. And this was a PowerPoint done by one of my RadPathers 4 years ago when he was at MS4, Joseph Abdul Malik, who is now almost an attending in GYN. But we got some great uterine RadPath images during his month, and yeah, he compiled them as well as some other images that we had. So I hope you enjoy this. Unfortunately, this lecture is not yet up on the building blocks. We're trying to get that up, and hopefully it will be there soon. So I will go extra slow so you can go through the slides. Again, we have the Anki RadPath deck, and for instructions on how to access that, go to the About section for our YouTube channel, but there's lots of great gyn-onc questions on there. So let's start by doing some anatomy of the uterus. So we have the fundal aspect, more cranial, and the cervix, more caudal, and the ovaries on either side. For the layers, the endometrium, myometrium, the muscle layer, and then the parametrium. What will the normal uterus look like? Well, it really depends on the age of the patient, and we'll be talking about that. In terms of imaging the uterus, ultrasound is the modality of choice for initial evaluation. No radiation, gets very high resolution, gets some great images. For problem solving, MRI is excellent. And a lot of times we're seeing the uterus incidentally when we're doing CT of the abdomen and pelvis, and we will often identify uterine pathology such as fibroids or endometrial stripe thickening. So remembering, especially for any GYN colleagues out there, how important the physical exam is and to correlate that with the radiology findings. So on ultrasound, this is a nice normal view to start with. We see something echogenic in this one, remembering from our initial RadPath lectures, things that are bright, calcium, air, that. This is going to be an IUD. This uterus looks retroverted, pointed posteriorly. But nice thin endometrial stripes in these patients as opposed to thickened ones, which we'll see coming up. And the premenopausal versus postmenopausal state is so important when evaluating the endometrium. And if you have a patient with postmenopausal bleeding and endometrial stripe thickening more than 4 millimeters, that's cancer till proven otherwise. So we'll get into that, but I just want to throw that number out, and we'll repeat that. So on CT, remember the bones will be bright. This is a CT. MRI, the bones will be more hypointense. Then we try to tell T1 versus T2. This will be T2, the bladder's bright. And what's the difference with this uterus? Well, there's a little baby in there. There's our bladder, there's the brain developing, there's the amnion that's bright. Let's start with the CT first. Here's our bladder. There's the uterus, nice and homogeneous. Barely make out the endometrial stripe, but it's definitely not thickened. And then the posterior component, we have the rectum behind it. We said this is our pregnancy one with T2. Again, this is great, no radiation. And a more normal appearing uterus, you see a nice thin endometrial stripe right there. And again, our anterior compartment, the bladder, and the posterior compartment, the rectum. So what can go wrong with the uterus? Again, important to know premenopausal versus postmenopausal. We'll talk a lot about abnormal bleeding. Again, it's important to know premenopausal versus postmenopausal. And ultrasound will be our first imaging modality to come up with a differential. And remembering from RadPath, tissue is the issue. Needing to get a good sample to make the final diagnosis. But a lot of times radiology will steer the tissue sampling. Is it a focal abnormality in the endometrium or is it diffuse? And that can be very helpful to help the GYN get a great sample. Okay, so I love mnemonics as much as anyone else. I'd never heard this mnemonic before for etiologies for abnormal uterine bleeding. There's a lot. So polyps, we see that. Adenomiosis, fibroids, we see that a lot. Malignancy, which we'll talk about. Coagulopathy, always important to know the INR status. And then ovulatory issues, endometrial pathology, iatrogenic, certainly, and then not otherwise classified when we can't figure out what's going on. Again, ultrasound's our first step. So, what can go wrong with the uterus? Well, it can have an irregular shape, and we'll talk about anatomic congenital variants. You can have masses in the uterus, pregnancy. So always check the beta HCG status, and you can have myometrial lesions, endometrial lesions, or just fluid in there. This is a little bit about embryology and the normal stages development of the uterus. I will leave this up here for a little bit. You probably don't want to hear me reading this to you. You can pause on this to take a look, but just realize that the uterus will look differently depending on the age of the patient. Again, so important to know pre or postmenopausal. There's our nice pear shape. We talked about some congenital anomalies. I'll leave this chart up for a little bit, but realizing the uterus can have different shapes, and that will have issues potentially with fertility. The biggest one, this is the thing to know for step 2, step 3, is septate has the highest incidence of miscarriages. You know, you get a fibrous or muscular septum on here, and the little embryo doesn't have as much good blood supply to grow on there. And you get a patient with recurrent miscarriages. No problem getting pregnant, but staying pregnant is the issue. Be thinking septate uterus. And the great thing with this is the GYN can go in and cut out the septum and return fertility to normal. That's always a very satisfying procedure. Sometimes we get asked in radiology to go in intra-op with those cases. And when the patient is able to have a full pregnancy, they're so appreciative. I'm not going to go into all of them, but you have bicornate, didelphys, arcuate. And the key issue here is that MRI is going to be the best way to evaluate these lesions. Like I said, it makes a huge difference, septate versus bicornate versus didelphys. And here's a nice RadPath example of a complete bicornate. You got 2 horns, a big cleft, and this shows it on the ultrasound, but before the baby was born, in the little yolk sac, gestational sac in one of the horns. Here we go on MRI, recurrent pregnancy loss, and we talked about that. That should make us be thinking of either a septate uterus or bicornate. We have a flat top here, and we have the 2 endometrial stripes, but then we have that septum, which can be hopefully resected. Okay, another Mullerian duct anomaly. So recurrent miscarriage, and what are we seeing again? We are seeing 2 endometrial stripes. Here's our MRI. Endometrial stripes are a little bit bright on T2. And this was a double didelphys uterus. And the good thing with this is it usually does not cause problems with pregnancy. However, the irregular shape can lead to miscarriage, and smaller uteri can lead to preterm labor. So again, something to be aware of. But again, the distinction between that and septate uterus, which can be where you can scoop out that extra septum. Okay, so we talked about some of the congenital variants. Let's talk about some of the masses. Again, another great mnemonic here. I never heard of this one. But anytime you have a uterine mass, things to think about. Okay, so enlarged uterus. So again, always think pregnancy. So hopefully we have the beta HCG status. But if they're not pregnant, fibroids by far is going to be the most common cause for an enlarged uterus. Adenomiosis, we'll talk a little bit about that. Leiomyosarc, we'll see some examples of that. Fortunately, it's rare, but unfortunately, almost impossible for us in radiology to distinguish leiomyosarc from just regular leiomyomas. Then we'll talk about endometrial lesions, polyps, like a little innie in there, carcinoma, and we are really going to care about the depth of invasion. Carcinosarcoma, hard for us in radiology to distinguish these, but it will make a big difference for the gynec surgeons in terms of the follow-up. Any of those sarcomas will be followed up differently than the regular carcinomas. And then it could just be some simple fluid in there, hematometria. So this is a patient who was pregnant, delivered, but is having some problems with bleeding after. So we do start with an ultrasound, and we see a thickened endometrial stripe and maybe some increased flow around there. Not the worst case I've seen, but anytime it's thickened with flow, we are thinking retained products at conception, which is, here's a great RadPath sample of that. That's what it was. So thickened endometrial stripe with flow after pregnancy, be thinking retained products. Okay, we said the most common thing in large uterus is going to be fibroids, and these can look like anything. Sometimes they're calcified, sometimes they're not calcified. We have seen some huge fibroids recently, and we're going to have a separate interactive lecture coming up, and we also have that separate talk about how to read pelvic MRI, where we have some nice fibroid examples. But right here, we have a CT scan and large uterus, not seeing the endometrial stripe. I can sort of make out a lesion there. And this is the gross specimen. So again, anytime you have a specimen, going to our RadPath basics, solid or cystic, you might say, hey, it's a little bit low density, but it's measuring 30 or 40 Hounsfield units, not like 0 or 10 like we get for water. So this definitely looks solid to me. And this is a lot of fun for our RadPathers when they go in, they take this out and they sort of slice it up, and you actually see it's solid as opposed to those big cystic lesions where you pop it and all this fluid comes out. So definitely a solid uterine mass. We're thinking fibroid. Okay, what's this going to look like on ultrasound? Again, the appearance is going to be variable depending on if there's calcifications. And sometimes they get so big you can't make out the endometrial stripe, can't make out the ovaries. This is one instance where ultrasound can be tough to make heads or tails of what else is going on in the pelvis. And sometimes there's so much shadowing you can't even actually see the entire uterus to get an accurate measurement. Again, we'll try to image it transabdominally, where you use the bladder as the acoustic window, and then transvaginally. Sometimes you see that these big fibroid uterus is actually better with a transabdominal. But usually we will see the uterus better with the transvaginal higher frequency probe, but you get a big fibroid with calcifications, your best bet is the transabdominal approach. Okay, so now we have fibroids. Now it's helpful for our GYN colleagues to say where these fibroids are located. So it could be pedunculated, sort of a big innie. It looks very similar sometimes radiographically to a polyp. You can have submucosal, sort of indenting there on the endometrial stripe. It can be intramural, that'll be the most common. And then subserosal. And then sometimes you can also have pedunculated coming outside the uterus. So what is this going to look like on MRI? So MRI, the bones aren't quite as bright as CT. And which one's T1, which one's T2? Well, this is T2, the bladder's bright. And this is going to be T1 with contrast. The bladder's dark, but it looks like we got some vessels enhancing. And we see this huge mass with areas of T2 hyperintensity within it. That can oftentimes be necrosis. But the uterus, when we give contrast, does enhance similar extent as the rest of the uterus. Sometimes you get a big mass like this, you're like, hey, is this the uterus or is this ovarian? But the enhancement shown similar to the uterus. And I think in this case, we can see it's actually connected. So we're thinking fibroid all the way, but sometimes it can be tough. And then this is for our GYN colleagues, how to treat this. Observe it if the symptoms aren't too bad, surgical removal, or another radiology procedure, uterine artery embolization. We'll see that coming up, but basically cut off the blood supply to these uterine masses. This is the hysteroscopic view. You see the big fibroid coming in. Okay, next patient, 49-year-old with 9 months of normal uterine bleeding and pelvic pain. So we have our MR. This is our T2, bladder's bright. We have the mass, which is going to be T2 dark, which is very good for muscle, and T1, and then T1 with contrast. It's enhancing, similar to the rest of the uterus. That tells us also that the fact that it's enhancing, it has a robust blood supply and may do well with embolization. Avoid a surgery if you can, if that's what the patient wants. And here they're going in, and you get the internal iliac arteries, and you see big time blood supply, and then you can embolize it, and this is the after, and not as much blood supply, and these fibroids will shrink and hopefully avoid a surgery. We said most of the fibroids are inside the uterus or hanging off, but sometimes, this is a patient who had hysterectomy and has pain, and we see an adnexal mass. So certainly this could be ovarian, but if she had a history of fibroids before, this could be a fibroid, extrauterine fibroid. And we note the signal of this on CT. It's sort of helpful. It looks solid. So it's definitely not cystic, so that's helpful. But we do the MR, it's T2 hypointense. It looks very similar to our previous fibroid, if you can go back or remember that one. But fibroids, we said, are dark on T2 and then enhance. So this is very good for a fibroid. We could put a couple other things in our differential, but extrauterine fibroid should certainly be high up there. And that's what this was. Issue is the issue. And this is we're going to have some neat images of this. Leiomyomatosis. Usually you just have the fibroid in the uterus, but it can be outside the uterus and it can be disseminated, intravascular, even metastatic, including this patient. We have to review our chest RadPath. This is sort of the normal lung, and then we have a bunch of solid masses in there. And then what do we have here? A bunch of air in the pleural space. This is a pneumothorax. This was a spontaneous hydropneumothorax that developed from one of those extrauterine fibroids. Okay, adenomiosis. This is a 44-year-old patient with heavy painful periods. Again, it's T2. The bladder is bright. You look at this uterus, I'm not seeing a discrete mass, but it looks sort of just globularly enlarged, and has these T2 hyperintense foci through the myometrium. This is diagnostic of adenomyosis. I almost said adenomyomatosis with the gallbladder, but this is adenomyosis of the uterus. An ultrasound, similar, no discrete mass, but the uterus just sort of looks enlarged and boggy. This is another case of adenomyosis, a big boggy uterus. Sometimes you'll see those cystic foci throughout, like we did here. Okay, leiomyosarc. Big teaching point. Almost impossible to distinguish from leiomyoma. You're going to get a large uterine mass. This is on CT, but I would say this mass looks a little bit more heterogeneous than our typical fibroid. Some more cystic degeneration here. This still could be a fibroid undergoing cystic degeneration, but one of the most helpful things is if you had a previous study and you get a postmenopausal female especially, and then this thing's growing, we really have to be suspicious for leiomyosarc. But ultimately, tissue is going to be the issue, and this is not a diagnosis we can make confidently with radiology beforehand. The sarcomas are aggressive. They often metastasize. So in terms of the treatment, It's going to be very different whether it's a sarcoma of the endometrium or the leiomyosarc like this. And the patient will have different chemotherapy, different prognosis. Again, leiomyosarcoma, hard to diagnose and will act differently. Mets will go to the liver, lung, upper abdomen. Okay, let's switch to the endometrium. And this is a 35-year-old with intermenstrual bleeding. And we have an INI here. Now, this could be a little fibroid or it could be a polyp. Sometimes it's helpful if you put Doppler flow on, you'll see a little stalk. That's very good for a polyp. We could also do a sonohistogram. You put water in here, and you see it's actually attached to the endometrium. Here's our nice vascular flow here. There's that stalk I was talking about. So this is almost certainly going to be a polyp, a big INI, which they can go in hysteroscopically. This is one of my most fun things to do with the RadPath students when we see they're doing hysteroscopies like this, and we get asked to help sometimes with the ultrasound guidance, and you can really correlate the imaging with the little INI right there with the hysteroscopic image, and then take it out, and the patient's cured. Okay. We're going to switch gears and talk about the malignancies now, endometrial carcinoma. So we are thinking postmenopausal females. And first step, ultrasound, thickened endometrial stripe. Again, our cutoff is 4 millimeters. This to me looks like 1 to 1.5 centimeters. Abnormal, thickened, it warrants a biopsy by the GYN. Again, this is sort of diffuse thickening as opposed to our polyp, which is more focal. Again, that's very helpful to give that information to guide tissue sampling. Remembering tissue is the issue. And so when the biopsy, this is for the GYN colleagues in postmenopausal patients, when endometrial thickness is greater than 4 millimeters with bleeding, it's carcinoma / hyperplasia until proven otherwise. The other thing to keep in mind or think is that the patient is on tamoxifen for breast cancer. That's something we're not going to talk about, but I just wanted to throw that out, that's another cause for endometrial thickening. So the tumor tipping point, what does the GYN oncologist really want to know? How deep is the invasion? This is hard for us to tell sometimes with ultrasound. I'll say a lot of times to tell with ultrasound, but if you need to know that ahead of time, MRI is going to be the best way to assess depth of invasion. Here's the gross specimen. You see the thickened endometrium, which ended up being endometrial cancer. And the big tipping point is, like I said, the depth of invasion. Is it less than 50%? Patients have a great prognosis. Is it more than 50%? Worse prognosis. Different types of endometrial cancer. I'll pause this slide just for a little bit, or you can pause it on the YouTube, that there are different, not all endometrial cancers are made equal. So very important to know the treatment will be different. Small cell, we see that not infrequently at our tumor boards, and it's always a great point of discussion for how that is going to be treated, because it's different from the other cancers. So endometrial cancer, a nice schematic here showing the staging. And again, the first question is depth of invasion, less than 50% or more than 50%. Okay, carcinosarcoma. Again, hard for us to make this diagnosis preoperatively. CT scanned in this postmenopausal female with bleeding. Again, we'd probably start with ultrasound, but we have the CT here, and I think you'll see it's thickened, very thick, some foci and gas. That gas could be from infection or it could be from tumor necrosis. Regardless, this is an abnormal finding. It is going to warrant sampling. And I would say this looks a lot more aggressive than our first patient, but no way to, preoperatively say, hey, this is a carcinosarcoma, but we're thinking something bad. It's going to be sampled. and that will direct management. And here's our nice gross specimen of a big innie in there. Again, looking at it grossly, hard to tell exactly. You know, you have something abnormal. A lot of times I'll do the frozen on these, see that it's not the typical endometrial cancer, and might warrant a further investigation while the patient's opened, looking for lymph nodes, especially if it's a sarcoma. We are going to be worried about that path of spread of disease. Okay, endometrial stromal sarcoma. Again, another sarcoma. We have our CT, thickened endometrial stripe, some gas. Again, that could be from tumor necrosis, recent instrumentation, infection. Hard for us to tell, but definitely abnormal. And we said sarcomas like to spread via lymph nodes. Just a quick review. Here's our aorta. There's our IVC. And here is an abnormal lymph node. Our last cause of a enlarged uterus, thickened endometrium is just simple fluid. So we do the ultrasound, and there's an abnormality. Trying to tell is this solid or cystic? Sort of low-level echoes, but we put the flow on, and there is no flow in there. If you remember the ovarian talk where we talked about endometriosis, this sort of looks like blood products to me. It looks sort of homogeneous. There's no flow in there. I'm not as worried about cancer as I was the other ones, which were a lot more irregular and had the flow. That's also a young patient, so we're not really thinking endometrial cancer. She had ablation 7 months ago, and that's the typical history we hear. They get an ablation, they get some cervical stenosis, and then the blood products just build up. Patient underwent the DNC, evacuated the large blood clot, and felt much better. Okay, as promised, there are going to be some interactive cases which we will have on a separate video. For these cases, remember the differential for abnormal uterine bleeding. Remember some of our basics, and remember that tissue is the issue. We can come up with a differential, but ultimately the pathologist will make the final diagnosis. And some take-home points. We had that differential for abnormal uterine bleeding. So important to know, is the patient premenopausal, postmenopausal, or actually pregnant? Ultrasound's the first step for uterine imaging. And postmenopausal female with bleeding and thickness greater than 4 millimeters, it is endometrial cancer till proven otherwise. We are seeing a lot more of this. I forgot to mention the risk factors, but extra estrogen and obesity. That is one of the biggest risk factors that we're seeing for causing a lot of these endometrial cancers. Hopefully you're picking it up early. Again, the tumor tipping point was, is it greater than or less than 50% involvement? If it's less than 50%, patients will have a much better prognosis. And we saw some sarcomas that looked very similar to our regular endometrial cancer patients. So we remember that tissue is the issue. To get optimize the to come up with the right diagnosis for our patients, which will ultimately optimize their treatment and prognosis. Thank you very much.